people making their way. So my name is Melanie Cavalier, and I'm the Chief of Innovative Care Delivery at the Maryland Healthcare Commission, or MHCC. The MHCC is pleased to present the MHCC MDAFP MedChi 2024 Spring Symposium, Enhancing Patient Experience Through Patient and Family Engagement, as part of our Learning Network initiative. This event marks the 19th learning event over the last 3 years. The sessions aim to enhance the knowledge, skills, and competencies of practices to deliver equitable, comprehensive, patient-centered care. This event is being recorded. The format for today's event is intended to promote an interactive conversation. We'll be starting off with a couple of poll questions, and we'll display thought-provoking questions throughout the presentation. To join the conversation, you may raise your hand or enter your thoughts and questions into the chat. For those of you who are not familiar with MHCC, we're an independent state regulatory agency that supports advanced care delivery and practice transformation. We collaborate with payers and providers to transition to quality-aligned, value-based care and to harness the potential of data in facilitating meaningful change. Next slide, please. So the next two slides outline important information about CME credits and disclosures. Following the event, you'll receive an email that includes a link to a questionnaire. The questionnaire requests feedback on the symposium and an application for CME or continuing education credit. We would appreciate your feedback, even if you're not applying for CME or CEU credit. So the AAFP has reviewed enhancing patient experience through patient and family engagement and deemed it acceptable for up to 1.25 live AAFP prescribed credits. The term of approval is today. Physicians should claim only the credit commensurate with the extent of their participation in the activity. Next slide, please. So the speakers and planners for this activity have no relevant financial relationships with ineligible companies to disclose. Next slide, please. Today's learning objectives include identify how patient and family engagement can lead to improved quality and safety, understand factors that influence patient and family engagement, including cultural factors, and recognize how practices incorporate the feedback from patients and families. So I'm going to start off by asking a couple of poll questions that include what's your practice specialty and has your practice implemented a patient and family engagement initiatives? So everyone should see those questions. We'll give people a couple minutes. So it looks like about half the people have started their patient and family engagement, and then another third haven't, and then about 17% are in the design or development phase. So that is great information. I'm going to look through the practice specialties and give that feedback a little bit later. So thank you to everyone who participated in the poll. Okay. So today we're going to start off with some opening remarks from Dr. Amar Dugarala, the president-elect of MDAFP. Then I'll provide an overview of the current Maryland landscape and select MHCC practice transformation activities. Next, we'll have 3 speakers who will discuss their perspectives on our main topic. We'll hear from Daphne LeBlanc, the subject matter expert from MedChi CTO. Kaylin Schweitzer from PCA of Hagerstown is unable to join us today because she's ill. And then we'll hear from Kiran Bone-Dermagni from IC Care that will provide practice perspectives. Daphne LeBlanc is going to present Kaylin's slides because she did work on that with that practice on implementing their patient engagement strategies. So next slide, please. So I'll now turn it over to Dr. Dugarala to proceed with the opening remarks.
Great, thanks, Melanie. and thanks for putting this together. So I'm a family physician. I'm in Western Montgomery County in a small two-physician practice. But first, thanks Melanie and MHCC, and also Becky Wimmer, our MDFP Executive Director, for putting this together. I find that engaging with patients and families is invaluable in providing patient-centered and comprehensive primary care. That's why I find this symposium so important. Our practice has had a patient family advisory council for several years. We're a small practice. We know our patients pretty well, but even knowing our patients really well in a small town, we found that having the patient family advisory council has been really invaluable in kind of getting at, some of the barriers that our patients have in engaging with our practice, in, what other difficulties they have with getting to specialists, getting medications. And some of those things don't always come out in a patient visit or in a phone call. So having an open dialogue with patients and their families has been really, really helpful for myself, my staff, our clinical staff, to get a better idea of what are the barriers for patients. So, and we're very lucky in Maryland with the Maryland Primary Care Program and the total cost of care model. In Maryland, we're at the forefront of primary care transformation. And of course, MHCC has been very helpful in guiding us through this process. So I'm very excited to hear from our speakers today and get this symposium started. And we're hoping this is first in a series of things that MHCC and MDFP will collaborate on. And of course, don't forget about getting your CME credit as well. So I'll pass that off back to Melanie.
Thank you so much. And, we appreciate the partnership and the ability to talk with your members and to assist them in their practice transformation efforts. Thank you. So next slide, please. So what does the Maryland healthcare landscape look like? We have 6.18 million people, and 16.9% of the population is age 65 and over. Next slide, please. So I'm going to provide a brief overview of some select MHCC practice transformation initiatives that are designed to support the Maryland model goals by readying practices to participate in value-based care models. Patient and family engagement is a key part of that transformation. Next slide, please. So advancing practice transformation has been an MHCC strategic priority for more than a decade. The first practice transformation was the Maryland Multi-Payer PCMH program, which ran from 2011 through 2016. The MHCC then partnered with MedChi, the University of Maryland School of Medicine, and the New Jersey Innovation Institute to complete activities in Maryland as part of the Transforming Clinical Practice Initiative from 2015 to 2019. This was a federal initiative that included over 124,000 clinicians. The MHCC has also contributed to planning and policy development for the Maryland Primary Care Program that Dr. Dugarala mentioned earlier since its inception in 2017. Next slide, please. So one thing that's really important is health equity. So the MHCC convened a health equity practice roundtable in March of 2022 with representatives from advanced care delivery practices. The goal was to advance health equity through the development of practice resources informed by the roundtable feedback. The feedback informed a symposium in March of 2023, which focused on strategies for identifying patterns of need in the community, building referral networks for services related to social needs, and connecting patients to resources. More information about the HE Roundtable is available on the MHCC website at the link on the slide. Next slide. So you've been hearing a lot about practice transformation. And in June of 2021, MedChi CTO was competitively awarded a grant to complete practice transformation activities. A crucial role of MedChi CTO is providing practice coaching on specific topics, approaches, and tools to help sequence and manage change essential to succeed in a VBC model. The program milestones include readiness assessment, workflow redesigns, and training. One of those trainings is specifically, and workflow redesigns is specifically focused on patient and family engagement. Approximately 45 practices completed round one in June of 2023. An additional 27 practices are projected to complete round 2 by June of 2024. We are still accepting applications, so if anyone's interested in getting some help with their PFE engagement, please contact me after this event, and I'd be happy to get you into the program. Next slide, please. So the majority of attendees have been part of patient and family engagement or PFE activities. So this has many modalities. It can be an anonymous survey or a town hall or a patient advisory council. So it's an ongoing mechanism to support meaningful relationships among patients and families, staff, clinicians, and organizational leaders. So when patient and family viewpoints are integrated to create a transformed delivery system, the practice is more prepared to respond to patient needs, priorities, and values. Next slide, please. So MHCC created a guide to provide Maryland practices with information and resources to help create, integrate, and expand patient and family engagement. And as always, all our resources are always free to everyone. Next slide, please. The key elements of the guide include the what, why, and how, frequently asked questions, tips, quotes from patients and providers, printable forms, and links to resources. Next slide, please. The guide's organized into 3 sections: creating a PFAC, the beginner section, the strategic integration, which is the intermediate, and expanding the influence and impact, which is the advanced. So practice should select the section most applicable to their needs and capacity, review the strategies, and then utilize the additional resources to further inform implementation. Next slide, please. So to address the transition to engaging patients and families virtually, we added an addendum on the use of PFACs during the COVID-19 public health emergency, or PHE. We gathered information through virtual focus groups and an environmental scan to assess how PFACs and PFBs were engaged during the public health emergency. And so although that's ended, many practices still choose virtual engagement for patients and families. So the addendum could be very helpful. Next slide, please. So the MHCC convenes peer learning network events like this one in collaboration with local and national health leaders on topics such as health equity, advanced care delivery, and practice transformation. More information on our learning network events is available on our website at the link on this slide. Next slide, please. So 2 recent events included the Health Equity Symposium that I mentioned earlier, and the evolving role of social workers in team-based advanced care delivery. Next slide. So I'll now turn the presentation over to Daphne LeBlanc, our subject matter expert from MedChi CTO.
Thank you. Thank you, Melanie. Good afternoon, everyone. As Melanie mentioned, my name is Daphne LeBlanc, and I am a practice transformation specialist with MedChi CTO. From the start of the MDPCP program about 5 years ago, I joined MedChi CTO and began to work with practices in transforming and implementing the program as well in all of its initiatives and understanding the different aspects. And PFAC was definitely one of the key requirements that practices had to implement. Next slide, please. Just a couple of questions to consider. As I go through my presentation, I wanted you to think about, so how do you currently get feedback from your patients? Are you doing a CAP survey? Do you have a comment box or any other, perhaps through your EHR, you have direct surveys that get sent out? How often do you review and assess or even implement those feedback given to you? What are the patients saying? Have you implemented a PFAC in your practice? That's also a key question. I believe Melanie also asked that in the very beginning. And if you have, how is that recommendation or feedback, how does that enhance your patient's experience and even your overall practice? And what does that look like for you? Next slide. So patient and family engagement, what does that mean? It provides an opportunity for patients and the families to advise and help promote change from their perspective, from their experience. Oftentimes we take it for granted and we say, oh yeah, everybody, because they say they look happy. They say they're happy, but there may be some small details that'll make it a little bit better for them, from the waiting room to the exam room to, even calling on the phone. And we'll talk about that a little bit later. The PFAC engagement, it really is just a roundtable conversation. It's an open forum for feedback and recommendations from the patients and caregivers' perspective. How do they feel? And you can pretty much guide what those questions will look like to initiate the conversation. It should include practitioners, clinical and non-clinical staff, of course, the patients and their families and caregivers, because many times, many of them have to come with someone to even see you, and their experience also counts, because if they're not happy, then they're not going to bring their relative to you. And this is a non-clinical conversation. I want to make that very clear. There's no conversation around diabetes or A1C poor control or anything like that. It really is about their experience, from the simple, tissue box to, but there's nothing clinical being discussed during these roundtable conversations. Next slide. How do I recruit? Where do I get these people from? You know what? Ask your care team. Many times they're engaged, they're having many conversations in the waiting area. Your front desk person knows a lot of your patients on a more personal level, because they're chit-chatting about, how the weather is or whatever it may be. And they may know who's going to be a good candidate, who's willing to speak, who's comfortable speaking. Find out if they're comfortable speaking in group settings. They have to be willing to share their experience and provide feedback, because that's the only way that would benefit others and themselves, and to help you make those changes. No special skills, no qualifications required. Approximately 5 to 6 participants. I've had practices that have had as many as 13. Sometimes they have to put people on hold and say, well, we have too many people. You don't want too big of a group, because then you have to find space for all of them. But you also, the conversation may go on longer. Most of these meetings are about an hour, hour and a half at most. And you can also rotate some of these patients from year to year. You can say, you know what, I'd love to have you, but we have too many so far. But however, we'd like for you to be here next year. Perhaps I'll put you on the list for if we need to make a swap. There are people who do it once a year, twice a year. It all depends. It's really up to you. But those are and you definitely want to have a diverse group. You want to show your entire patient population as best as possible. Next slide. Where can we do it? In person? Always a good idea. Melanie mentioned during COVID, we had to go virtual for everything else. So virtual became also acceptable. You certainly can do a virtual, but you have to be sure that those participants are comfortable using the technology. As we talked about, many of them are seniors and many of them are very savvy and know how to use it, but some are not. So if you've chosen to do it virtually, just be sure that those that you've elected to participate can use the technology, so it doesn't cause a lot of delays in starting the meeting. If it is in person, you may want to offer light refreshments and beverages. Perhaps consider a small gift for participating. That's a nice incentive. You get a $25 gift card, grocery store, gas card, whatever it may be. Set times that are convenient for the attendees, right? Or for yourself as well. After hours, after work, office hours is usually a good time to do it. Some people have done it on a Saturday morning, perhaps, but whatever works for everyone, I say go for lunchtime. It all depends, right? But definitely look to see what's more convenient and that would meet everyone. So again, to avoid any delays in setbacks. Next slide. And the topics, I said I would mention that earlier. What do you talk about? These are just examples, right? Front office. Is the waiting area welcoming? Is it comfortable? What could I do to make it better? Can you give me some suggestions? The exam rooms, how clean is it? Is it clean enough for you? Did you find supplies? Something as simple as hand sanitizer or tissue, when you're in the waiting area as well as the waiting exam rooms. Should I, you'll be surprised. Many times we've heard that where I can never find a tissue in here. I have to use the hard paper towels to blow my nose. Simple things like that can really strike up a conversation and help you make those changes in your practice. The next slide. A few more examples. Access to care is critical. You find that in a CAP survey. Most of these questions I've seen CAP surveys so many times. It's one of the biggest topics because patients are very share feedback when it comes to that. They're very typical about that. I can't reach you on the phone. I tried to leave a message. No one called me back. Is my messaging too long? Sometimes, we think, we're trying to give them as much details so they can pick, make their selection in the menu. Sometimes it could be too long. And, and the patient's like, oh, forget it. And they just hung up and call back, hoping that someone would just pick up the phone. Ask them about that. New patients, can they find your office? Is your suite number easily locatable when they're in the parking lot? Right? Is it to the left, to the right? Is it inside the building, second floor? What does that look like? Can you provide more information when it comes to a new patient? Would you recommend, what would you recommend to make it a better experience? You always want to ask that question because, again, what does that look like for them? Communication is another big topic. Are calls answered in a timely manner? Do I speak in words that are easily understood? Am I using way too many medical terms for you that goes right over your head? Or even the caretakers as well. Sometimes, when of course you give them the opportunity to ask questions, but sometimes the information is just so over the top for them that you may not realize it because it's just, secondhand for you. It's part of your everyday, but is it easy for them to understand? And you'll be surprised of the responses there. Next slide. Then you have to implement, right? Have the meeting, you've got your participants, you had the meeting, and they've given you some feedback on what you can do. And I say, make sure you take some notes, discussion points. What did they say? How did they, what were they looking for? Just jot it down, right? Who was there and what did they say? Keep those notes because you're going to refer back to them. Nothing, you don't implement everything at once. When they ask you, oh, I need some more comfortable chairs, we're not going to remodel the entire exam room, right? We're going to do things that are feasible. And you start with the small ones. I always say, start with the simplest changes first, like the tissue box in the waiting area. I use that example a lot because I hear it a lot. Gradually implement those recommendations as you see fit, as your budget can respond to it, and set timelines for some of these changes because again, they are very relevant to the patient's perspective, but how can you implement it? And patients will notice the small differences. They will notice the changes. When they're in that meeting, they heard what the other patient said, so you really want to make those changes because they're like, oh yeah, such and such said that they wanted more tissue box. Look at that, there's always a tissue box in here. So it's really important that, but you set yourself some timelines from the small ones to the big ones, and you can definitely achieve many of these feedbacks and recommendations that are given to you. Next slide.
So why don't we go ahead back to slide 20 and go through some of the questions? And if people would like to kind of weigh in on some of these. So the first one is, how do you currently get patient feedback? So if anyone would like to discuss how they're doing this in their practice, you can either raise your hand or put it in the chat. We'll give people just a minute or so to respond to that question.
Hi, my name is Doris.
Uh-huh.
Can you hear me?
We can.
Okay.
Welcome.
Yes, I am currently working with 3 safety net clinics of Montgomery, and one of the clinics that I am with, I know that they have a barcode where patients scan it and then they can do their patient satisfaction. And that's and I see that as soon as the patient responds, they take care of any feedback that they are getting from their patients. If the patient is complaining of how much time they were waiting before being seen by the physician or different things. But I see that they get that email and they are like promptly, like trying to tell the patient, they are sorry, they were like, we'll work on it, and it is very nice to have that type of feedback. And
Oh, go ahead.
yes, and that clinic is the Muslim clinic in New Hampshire Avenue.
Thank you for sharing that with us today. We
You're welcome.
appreciate that. Becky, would you like to read some of the things people have put in the chat? I didn't see anyone's hand up.
Yes, a couple of respondents said Press Ganey surveys and post-discharge phone calls, quite a few surveys, CA, HPS surveys, NRC surveys. Someone uses a QR code for patients to submit feedback instead of comments box, and also send patient satisfaction surveys from their EHR every quarter. They use an outreach department from CAHPS and forward any concerns when they talk to inpatient and ER discharges. More patient satisfaction surveys.
Great. Thank you to everyone who has replied to that. Someone said a SOGO survey. That's a different one. I don't think I've seen that one. SOGO survey. So the next question, how often do you review, assess, and implement the feedback that you're given? So, some people do this once a year, some people do it twice a year, some people do it quarterly. So, we just like to hear from a few practices on how often you're implementing the feedback. And you can either raise your hand and speak if you'd like, or you can just put it into the chat. Somebody says monthly, great. I think a lot of our speakers are doing it twice a month. Daphne, do you have any comment on like what you see a lot with practices, with like the how often people do it?
In the MDPCP, they must do it at least once a year, but many of them have done it twice a year, every 6 months. And again, because they've had so many participants willing to join, that they would do one session early, first 6 months, and then another 6 months later in the year. With the ones using comment boxes or QR codes, have to do it a little bit more often, because then it tends to pile up, and it makes it a little bit more difficult to kind of follow through and catch all the different comments. So I think those probably do it monthly, and I see a lot of people are commenting that they do it monthly.
Yeah, so Becky, do you want to kind of summarize the feedback that we saw we see in the chat?
Yeah, I would say most indicated monthly, is in some quarterly or 2 to 3 times a year. Someone indicated that implementation is more challenging. Does anybody have any comment on that? Daphne, do you?
Implementation is the hardest part, right? What do I do? Where do I start? Which one do I do first? And like I mentioned in the slides, you want to assess all of the feedback. You really want to break it down and then set yourself timelines. It depends on what they're saying. And again, start with the simplest changes, the simplest fixes first. And gradually work your way up to, remodeling the waiting area if you have to. But having paper on the exam tables and things like that, it really does depend on the feedback, but really assessing it. I think that's the key part, is once you've gathered all the data and you've looked to see and you break it down and you see, okay, how many people, CAPS does a great job to tell you exactly how many people have answered in which way. And when you see that, then you're thinking, oh, wow, this might need to be a priority, because everybody hates this or everybody would like to see that. So again, because you're looking at the patient's perspective, you really, if 20 people saying, that you need to have better magazines in the waiting area, you probably want to subscribe to a different, to a new magazine company to get them newer or updated magazines in the waiting area.
Thank you. Thanks to everyone who responded. So I know about 50% of people said they had done some form of patient and family engagement. How many of you have actually done a PFAC in your practice? If you've actually implemented a formal PFAC, if you could just put that into the chat for us, or if you'd like to come on and talk about recommendations that enhanced your patient experience and overall practice from any type of feedback. If anyone would like to share that with us, that'd be great. I mean, as Daphne said, we know the people who are in MBPCP, they're required to do a PFAC, so we know those people have probably done it. So. Because when I did the analysis, it looks like about half the people that responded are primary care. A few hospital representatives, some behavioral health, some patient advocates, and some health systems that are online today. Okay. Yeah. So is there anyone who wants to talk about something that they implemented as a result of their PFAC that they feel really helped their practice? Would anyone like to come forward with that?
I can share. I'm Justina Starvin from Mount Washington Pediatric Hospital. So we do have our outpatient medical practices are much larger actually than our hospital patients. So we have a combined patient family advisory council. All of the members are in our medical practice because they're the ones who are more engaged. It is chaired by a patient, like a patient family member chairs it. Before COVID, we used to have food. We used to provide babysitters because we're pediatric. If you needed the parents to come, that was a problem. Now we're doing things on Zoom. And we bring a lot of things to the patient family advisory. Like it's becoming more routine whenever we're changing something. We involve them with our new medical record. We involve them with the patient portal. We involve them with just, if we have we did construction on a new kind of physical therapy area. We involved them with that. So it is kind of a really nice thing to include. And for us, we do specialty pediatrics. They tend to be very savvy patient families because if you have a child with any kind of complex medical needs, you are everywhere. So they'll say, oh, I went over to Hopkins, this is what they have. Oh, I was here, this is what they have. And I was the person, so when they talked about surveys, they said, please don't send us a survey. So I don't know about you all, whenever you go to the doctor's office, before you hit the elevator, there's a survey in your box. And they're like, please don't do that. So they were more interested in a focus group because they are, especially if you access services a lot. So I know the adult population probably do too, like some chronic care, they're getting surveys all the time. So I think the patient family advisory, and you do have to be careful. I think every once in a while you just get someone who's just a griper and complainer. I mean, they're vocal, but it's not constructive. That would be the only, and you kind of hear what they have to say. You don't kick those people out, but you do have to be careful with, is this productive or is it just making things sideways? So
do you feel like you made different decisions than you would have if you had not involved the Patient and Family Advisory Council? Did it kind of steer you, do you think, in a different direction with some of the things that you implemented?
Oh, for sure. I mean, some of the things are, and I guess we're a younger population because it's pediatrics, but just really leaning into any kind of electronic tools, mobile registration, remote access, all of those things. They were, because that was newer for us, and they were clearly, they like to have everything on their phone. So our population does. And we're a small hospital, or medical practices too. You're not spending the big bucks cutting edge technology. You're kind of seeing what other people have. So it is helpful when we are doing new technology to they're the ones who are really guiding us on that, of the brand new things out of the gate. So that's what I feel it's the biggest thing, is that the new stuff should we, do they really want it? Because it's expensive,
Right.
so.
Thank you. Your feedback has been very helpful. Thank you for sharing with us today. So Justine, let's go ahead and move into Kaylin Schweitzer's slides. So unfortunately, Kaylin's ill and she's not going to be able to be with us today. Daphne LeBlanc, who is our subject matter expert that worked with the practice, is going to be presenting some of the things that they did in primary care associates at Hagerstown. So you can go to the next slide, Justine. So two questions are, what challenges did you have? Because you're going to hear about some challenges they had, and then some adjustments that they made based on those challenges. And then about the ways, which is kind of what we just discussed, the ways that your patient family feedback has benefited your practice. So Daphne, I'm going to go ahead and turn it over to you to let you continue through.
Okay. Next slide, please. So Kaylin from PCA of Hagerstown joined the MDPCP program under the MedChi CTO about 4 years ago, almost from the very beginning. And at first it was a little challenging for them to figure out how do they recruit. Recruiting, I think, if I recall correctly, was one of the ways that one of their first challenge, and we helped them through that. But these are her slides, but I definitely recall some of the experiences that they went through in creating the PFAC originally, and where and how far they've come over the last couple of years. So first, like she said, navigating the terrain, finding your way, selecting the right members, right? How do you know who should I select? How do I get and they are predominantly, I don't remember the percentage, but they are predominantly 65 or older. They have a very large population of seniors in their practice. And how do you select the right members? Those who are capable of coming and with many illnesses and disabilities. So that was a challenge for them. Clarifying the mission, communicating the purpose of the PFAC. Why a PFAC? What do you say to me? What do you want me to come for? Patients and families had a lot of questions around that. The breakthrough, overcoming those barriers and engaging those patients and families and helping them find the value of the PFAC was a major breakthrough for them. Next slide. The office-wide collaboration, she had every member of the office contributed to it. I remember having a meeting and it was during their lunch hour, and their entire staff was on Zoom with us, right in front of asking questions and taking notes right before as they were in the process of implementing a PFAC, and everyone was engaged. It was very important to them that their entire team understood and realize what the benefits were for them, right? Because they're like, why are we doing this? Why do we want to know what the patients think? So really engaging them was a major piece for them, and very important piece for them. Diverse representation. Yes, they are predominantly a senior population, but they also had, some younger members. I mean, they're adult care, but they wanted to make sure that they had a variety. And again, not based on health conditions, but just based on diversity, population, the community, and even some of the family members, when they actually engaged a lot of family members so they can get some of the younger, daughters and sons to come and help them get a better perspective also on behalf of the patient. Critical thinking, emphasizing the diversity of thought. She talked a lot about deliberately avoiding selecting individuals, to mere agreement. You don't want somebody to just come and say, yes, we like everything. Yes, this is great. You don't do anything wrong. You really want to find out truly, some of the, as much as we love praise, but is that really going to make us change, right? It's just going to make us happy. So we really want to find out some of the key components of, so your questions was very critical on, very important in how you selected the questions in your agenda to try to pull out that feedback and not just get, like she calls it, a superficial praise. Next slide. So how did we get this information out there? They actually leveraged Facebook for their PFAC awareness. You know, social media was the way that they went. It was eye-catching. They didn't do that the first year. I believe it was the second, if I recall correctly. But it was necessary for them because they realized that a lot of their patients were on Facebook. Some of their family members was on Facebook, and they talked about a PFAC and what does that do for us. Office flyers, definitely you want to post it, you want to talk about it, make it eye-catching, put it in the exam rooms, whatever it takes to get people to ask, oh, what's this PFAC? How do I join? And they did get a lot of feedback. A lot of people wanted to participate. They were one of the practices that had a large group. One of their meetings was over 15 people. Direct patient engagement, you know, engaging them in the conversations during the office visit, you know, in the waiting area of your front desk. If you're, especially when your whole team is aware of this PFAC, their front desk utilize that time while the patients are waiting to kind of engage with them about the PFAC. And whether or not they would be comfortable in joining, and you know that what is a PFAC and things like that. So that was also very important. And you know, they went one extra step in personalized invitations. They sent letters inviting patients to participate and explaining what a PFAC was. They did get a lot of responses from that as well. People felt that, that they were singled out, but it was important that they got, oh, I got an invitation for me to participate. So it actually gave them a lot of positive feedback from that as well. Next slide. So how do I adapt? You know, questions centered around the office's performance, minimal engagement and discussion at first. People were just not really responding. So they refocused on patients' healthcare experiences, and it actually just opened up. So it wasn't clinical questions, but your healthcare experience overall. And people opened up and had more insight at that point. Um, they expanded to inquire about community needs. You know, what in our community do you find challenging? How can I help? You know, something as simple as getting to transportation. They're in Upper Western Maryland, and transportation can be challenging for some of these seniors to get to the lab, to get to, you know, the imaging centers. And how can I help you through that? And they were able to make some major changes, you know, just them having the resource in order to help those external needs for their patients. And that made a big difference in the overall experience as it relates to their healthcare overall. Next slide. Turning the insights into action. So now we have to actually make those changes. You know, it was a diverse membership, like she mentioned, you know, broad spectrum of perspective. There was an increase in patient engagement. Members expressed a desire for more frequent meetings. They had, you know, so now they're actually at 2 a year. They started with 1 every year, and I think the last 2 years they've been doing 2 a year. They're even considering quarterly because they get so many people who are willing to participate, and they rotate their PFAC members, participants. They do rotate them from, you know, so again, so they get a variety of feedback and recommendations from different perspectives, different people. And they extended the program, you know, greater involvement initiatives, you know, NDPCP hard. They started to pull patients from different categories to help them, again, enhance the overall delivery. Next slide, please.
So thank you so much, Daphne, for stepping in and doing those slides. So I do remember that, you know, a key part which you talked about of her presentation was initially they didn't get people, but then what they said is, what's your overall healthcare experience? So similar to what the lady was sharing with us earlier from Mount Washington Pediatric Hospital, you know, a lot of people, they go to a lot more places than just your practice, right? So what are some things they like from other practices that you could bring in, or what are things they don't like in general that you know, that maybe you're doing, and this particular patient hasn't said anything, but maybe somebody would. So it was very interesting to hear, you know, their experience and how that changed the feedback they got when they opened it up to the general healthcare experience. So would anyone like to discuss challenges that they've had either with recruiting patients or implementing? I know some people have said implementation is kind of where the sticky point is. So would anyone like to share anything about the challenges that they've had with, doesn't have to be PFAC, it can be any kind of patient and family engagement. Maybe it's just beginning it.
Yes.
Oh, yes, please.
Hello. Hi, my name is Miriam, and I work for Chesapeake Healthcare in Salisbury, and I work with the Hispanic population, representing the population here. That it's a big population in our area, and I do face a few challenges, and of course, the language barrier is a main one. And in order for them to understand when they come to United States and they have to face a new health system, it's a challenge, and they feel frustrated. They don't know where to go for their medications, that they don't know that they need to make a follow-up appointment with their providers. They don't know that they have an annual physical exam that we provide for them to just prevent any medical conditions. They don't know that they will have to call their providers to request for refills of medications, because culturally, we don't do that in our countries. We go to our doctors when we feel a pain, when we feel a discomfort, when we make an appointment, and the doctor take care of us on that date or on that visit, and that's all. And then we come back again when we feel another pain. So it's a matter of educating this population, or the non-English speaking population, of people who come from other countries, to learn the new system that we have here in the United States. And it's been every day that I receive a phone call of a new patient, I have to start with that education. And complaints are every day, frustrations are every day. And I say the main reason is the language barrier. So I thank you very much for the opportunity to be in this webinar, because I can learn how to address this with the upper level, with our chief officer. How can we implement some ways to hear these people one more time on their frustrations, and try to solve these problems in the processes that we have in the office, that is not helping them to understand all the healthcare part of them. So that's my input. I think it's necessary to express this part, since, as I say, Maryland has a good amount of Hispanic population, Haitian population, non-English speaking population that needs to be taken care of.
Well, thank you so much for sharing that with us. And, cultural differences are something that more practices are recognizing and making efforts to deal with those. So thank you so much for talking about that today. It's very important that we do recognize that not everyone's experience is the same, and that we need to meet the patients where they are and try to accommodate them and educate them, like you said. So it's great information. Thank you. Does anyone else want to share today their difficulties in patient and family engagement?
Yes, I feel that something that is happening in Maryland as well is the shortage of healthcare professionals. Before, in the we connect patients to get their screenings for breast and colorectal, and there are resources, but there are limited resources, and the demand is higher than the resources available, and the waiting lists are too long in a lot of the programs. And then there is for example, we have a program in Montgomery named MCares, and then the uninsured population is so high, and that it's not enough the locations that we have that are connected with those resources.
Yeah, so the provider, it's an issue, right? Across
Yes.
the whole, and nationally, but
Yes.
definitely in the state. So that is one of the things that we're looking at as part of the primary care investment work group is workforce issues.
Yes.
We do recognize that. Obviously, the state does recognize that. And we have a couple initiatives in place that are trying to address that. And then obviously we're looking at things we can do in the future to address that even more. But thank you for bringing that to everyone's attention, that certainly is an issue. It's not that people don't want to get the care, but they have trouble scheduling the care in a timely manner because there's just not enough providers.
Yes, yes,
Yes.
because it is a little frustrated for the patients that your doctor recommended a screening, but then you have to wait 3-5 months to get it,
Yeah.
or even more because of the programs. They have limitations of how fast they can schedule them now. Like before, I remember we used to have we could like arrange an event in a month and we could do it. Now it takes more time to be able to do events because they have limited staff in the locations that we work with.
Right. So one thing that I've read and heard is that, that obviously after COVID, there's been big changes in staffing. And while some areas have rebounded to some degree, it's still not to the pre-COVID levels. There was, I think, 50% or something like that, less staff now than there was 5 years ago. I think those are some of the statistics that I've been reading. So it is real, and then, the patients are feeling it and the practices are feeling it. So, but thank you again for bringing that to the attention of the group today.
Yeah, and thank you. I'm happy to hear that you guys are working in resolving that problem.
We're trying to. That's a big problem to try to resolve. It's a big problem, but we are aware of it and we are working on it. So,
Thank you.
Okay, well, if anyone else would like to speak, otherwise I think we'll move to Kieran's slides, which start on slide 34. Thank you. So Kieran, I'll turn it over to you.
Right. Hi, good afternoon. My name is Kieran Bone-Dormini. I'm an office manager with IC Care, which is an internal medicine practice in the Largo area. We're just down the street from the new Capital Medical Regional Center. Thanks so much, Melanie and MHCC for holding this forum because it's so important to show the resources and share the knowledge of how to engage our patients and families. Next slide. I think as I talk about a little bit what our experience is in our medical practice, we can look at these questions. So I'd love to hear from people about, what surprised you about your patient and family engagement efforts? How did you reach out to patients and participants? And have you had any luck using social media? And what would you like to do differently going forward in the future? Next slide. Cool. Yeah, I started as the office manager in 2020, right in the middle of the pandemic. We had just started our PFAC the year before, and the practice has been around for half a century. And so I was coming into the office, taking over as the office manager from a well-established practice that had, generations of patients coming to it. And I really wanted to, get to know, what we weren't doing well. Like I was in the office kind of hearing the rhythms of the day and, crazy phone calls. And there was sometimes just folks frustrated about wait time. And so there was just a lot going on and reaching out to a subset of patients for me was a great way of learning of, what are the challenges most important to our families and how we can address them. Next slide. So the stories we tell are important. We are internal medicine practice with a holistic healthcare philosophy, meaning that the stories that patients say is part of giving information to the provider as to what could be possibly going wrong, but also having patients kind of explain what's going on in the world. So, for example, a patient can come in and say, hey, I have a pain in my foot. And, what does that mean exactly? Is that part of like the whole leg, or is it something that we kind of need to dig into some more? So we really emphasize, really listening to patients, and the PFAC is an important way of doing that outside of the clinical setting. Next slide. As I said, the stories that we tell are part of the healing process. It's giving information to our providers. So from the front desk to triage with our medical assistants. And it's also part of the reason why we're here. We're here to kind of listen to each other and help, build a community together. So kind of having an emphasis on what people are saying and being heard is really important. Next step. Next slide. So our challenge was, like I said, there was a lot going on. So I wanted to figure out how we could improve our service and figure out what were the issues important to our patients. And, as we moved into the next half century of our practice, we wanted to really move and grow with values that were important to both our community within the organization and without the organization. Next slide, please. So our internal priorities were establishing organizational priorities that address the patient service issues, and also continue to promote highly effective practices that serve our patients. On the external side, we wanted to improve the patient experience and help them become ambassadors for, the great work we're doing, the small style of healthcare that IC Care is doing. And we're using this to both on the internal end with our community, strengthen communication, collaboration, and promote family advocacy and involvement. Next slide. Next slide. So our approach to reaching out to patients we're going to try out some new things. This is in the middle of the pandemic, and new technologies were coming in, and we wanted to make sure that new technologies are available for our population in PG County. We also wanted to be really transparent as to why we were making changes and to have clear objectives. We wanted to check in with our patients, so the PFAC was a great way of checking in and then trying it all over again, having a continuous loop of trying out things and making sure that we were growing with the values that were important for our community. Next slide. So what we did, so we invited patients and family members through flyers in our office. We posted flyers in the office. We had about 80 emails that we started to collect. So we sent out an email to folks, and we had sign-up sheets in the office as well. For folks who didn't want to participate in a group meeting or didn't have time, they could use surveys that we had in the office or that were included in the email that I sent out as well. And then we ended up having 2 to 3 meetings a year. And usually we offered one virtual, like over Zoom, and then one in person where we might have a few snacks, but it was a time for patients to come together over the telephone, over video, or in person. Next slide. So for each of our meetings, we've had 3 to 7 attendees, and we got great feedback on services that we were thinking about, but weren't quite sure if it would resonate with our patient population. So it was everything from, having more office hours. We have 1.75 practitioners in our office, and so we wanted to add extra hours. So we talked about having another Saturday hours for our patients. And then we talked about creating learning circles of folks, and the topic around diabetes came up. And so we talked about what other type of patient education. And I think this could be really important for newcomers, new immigrants to our communities that want to learn, if they're focused on just the pain aspect of healthcare, they could kind of participate in topics and conversations that are outside the clinic. And then another idea that folks had were like, how do we get, written notes so that we can take that with us even after the encounter with a practitioner. It was a great way to get marketing ideas also. So it was great to hear about, what the good work of the office is doing. So gathering those testimonials, how people have evolved with the practice and how our office has helped them get better. And it was great to hear about, what kind of social media channels could work. We're a small practice, and managing social media is something that we haven't really done at all. So that's a question I would love to hear more about, if people are doing that at all. And other marketing ideas included, having health booths so that we could kind of talk a little bit about what we're doing, or offering health screenings for different events at fairs, schools, or churches. And we also got great input as to using our hiring practice as we were trying to bring on new nurse practitioners or other physicians, that they could shadow our practitioners, and then also just have the PFAC be part of our hiring process. And we got folks to volunteer to be part of round 3 of our interviews with nurse practitioners, and they provided a great perspective so that potential recruits can see if this is the community for them, and also have patients just learn about new practitioners. And they also suggested that we incentivize our current staff members to bring new patients to our practice. We talked a little bit about how it's great to get great feedback, but it was also just a good forum for people to share kind of frustrations and kind of really dig a little bit deeper as to what they were seeing at other practices, or where they thought we could step up and grow. And we, in our PFAC, we included our medical assistants, and it was a great opportunity for them to kind of hear from a group of patient and family members, and to participate in stuff outside of the clinic. Next slide. Yeah, I talked a little bit about recruitment. We got folks also to suggest quite good interview questions for potential medical assistants and for our nurse practitioners. And we got folks to volunteer as well for those interviews. And we're able to get them to actually help us wordsmith our kind of refined philosophy of healthcare, and with a focus on the partnership of healthcare, of helping folks work with different providers to reach their health goal. And so they actually helped us write a new office manifesto, or philosophy around what we mean around trusted care. They also became great ambassadors for what we were doing, and were able to kind of spread the word about changes that we were bringing to our office. And our MAs got to step up and shine in new ways, and kind of highlight their experience with the office, working with patients, and just participate in this kind of growing kind of conversation around what we wanted to do with the practice and new services we wanted to bring on. Next slide. So the PFAC really fell into our kind of philosophy around positive health, and it's a partnership between the providers, the medical assistants, patients, and their families to look at all the resources in their spheres, and using all of those together to get healthy. Once again, my name is Kieran. Here's my contact information. Love to hear from you.
Thank you so much, Kieran, for sharing about your practice. Let's go back to slide 35 and Kieran's questions. So I think we've talked a little bit about the first one, but I think I know you were particularly interested in hearing about social media and who's effectively using social media and reaching out to their participants. So if anyone would like to speak up about that, we encourage you to do that, or put it into the chat right now. And I know Kaylin's practice that they used Facebook. When they gave you feedback, did they give, Karen, did they give you any specific types of social media that they suggested your patients, or not?
No, not really. Yeah, not really. I've heard though from some patients that LinkedIn is a way that more and more practices are using to kind of broaden their message to kind of professionals that are looking for healthcare professionals. And then pay. I've also spoken with all the folks about paid advertisement on things like Facebook, but not specifically about how to engage patients and families.
Does anyone want to comment on social media that they're using to engage patients? Are any of you guys using Facebook, or I see someone's off mute? Would you like to, Raul, would you like to?
Sure. Yeah, good afternoon, sir. I wasn't sure how to raise my hand here, but thank you for allowing us to speak up on this. But here at Luminous Health, we use a couple different social media platforms. We use LinkedIn, and we also use Instagram, and also I think Facebook too. So our marketing team really manages all that as far as what the posts are, and a lot of those things are to create awareness around behavioral health, either opportunities or ways that we can help patients in our communities. And then we also use social media to show, kind of create awareness around internal events that we have at Luminous Health at either the outpatient practices or on campuses, like the hospital campuses. So that's one way we use social media to kind of get the word out as to what services we have to offer. And then also any events that are coming up, whether it's a free event for like our smaller communities, or if it's just something that we want to invite patients to come in and see what it's all about.
So when you say you use LinkedIn, like, are your patients your connections, or is that more reaching out to the professional community? How are you using LinkedIn?
Yeah, for LinkedIn, it is more for professionals. My preference was if we shared those things on Instagram and Facebook, we get more of the community or the patients. But we do share things on LinkedIn that are more, if we are announcing like our patient experience banner winners, where we hold that across the organization for, again, the outpatient practices, and then also our inpatient units, who is doing a great job, really just highlighting those. But that's when we use LinkedIn more for like professionals. Yeah.
Thank you for sharing that. We appreciate
No
it.
problem.
Would anyone else like to share their experience with using social media with patients? Give you guys just one more minute and then we'll move on to our final question for today. So the final question I think we have for today is, what does the future of your engagement efforts look like? And I think I'm going to go back to the panel to let them start, but I'd love to hear from the audience. So Daphne, what do you think the future of patient engagements? What do you see as changes people are looking to implement as they move forward now that they've been doing it for a few years?
One of the engagements that one is we'll start with a lot more people want to participate there when they see the changes, no matter how small they are. I think even the ones that were not participating in the PFAC, some of the other patients also see the changes and they wonder, what brought that on. And it helps to engage more conversation and more participants. I think over the years, and I use PCA of Hagerstown as an example, Kaylin, with all the years that she's implemented it, again, they're constantly changing. I think almost every PFAC meeting she has a new group of participants, which is amazing. I had one practice that actually implemented a food pantry. In one of their PFAC meetings, they found that, again, looking at needs, right? The conversation around needs came up, and a lot of patients could use some basic household needs, because things were just so expensive. And it wasn't just food. It was small samples or, small travel size of deodorant or household cleaning products, things like that, that they just didn't have the means and the funds to buy for their household, and they were grateful to have something like that. And that pantry, over time has grown and really helped a lot of people in with various needs. So I think, yeah.
So moving definitely into that health equity social needs realm, right? Moving more into addressing those and addressing the cultural issues that we've heard about earlier, addressing some of those the needs, the more meeting patient where they are, right? Addressing that a little bit more. Okay,
Yeah,
great.
when the practice that talked about the language barrier,
Yeah.
how that's a major challenge for them, and it was also in PFAC that they found that, the message in your phone lines is completely in English. Not every practice has that option to say, if you'd like to hear this message in Spanish, please press 1 or 2 or whatever. And again, to better understand your population and what their needs are, you know, I think a lot of that came out of different types of patient and family engagement efforts.
Yeah, great. Thank you, Daphne. Kieran, what about you? What do you think the future of your patient and family engagement? What's kind of on the horizon for you guys?
Yeah, I think keeping it up because it is I think keeping it up and just having better practices around kind of sharing the next steps with the patients and just having good kind of like kind of committee etiquette of kind of following up with patients. I like
Right, yeah.
that's something I want to work on. And then I think more involvement around kind of just new technology, kind of trying out new technology, because I think the PFAC was really helpful for us, kind of sprucing up things in our office and then working on developing our care team. And I think now we can look a little bit more into some like little niche areas like new technology options.
Yeah, that's great. Thank you for sharing that. It's interesting that you mentioned the follow-up because, when people invest their time and effort, they do want to know if something's coming of it, or maybe why not. Daphne has mentioned kind of the redoing the waiting room, which we've heard from a lot of different practices, but you can't always afford a complete makeover, right? So maybe you can invest in a couple things, but they may say, this was a great suggestion. We understand that it needs to be done, but our practice doesn't have the resources at this time to do this. So, just recognizing that those were great ideas, but maybe it's just not the right time for a practice to implement that. So I think that that's a really important point that you made just now. So thank you for sharing that. So I'm gonna start winding down. Does anybody have any final questions for our panel speakers today? I'm not seeing anything. Becky, do you see anything or anyone's hands raised?
I do not see anything.
Okay, great. So I do want to thank our insightful speakers and all of our attendees. The recording and slides is going to be posted on the MHCC website. I'm sorry, can you go to the last slide, Justine? Sorry. My contact information is on this slide. If the 50% of you that have not implemented your patient and family engagement efforts, our team is available to help you with this. Everybody is very experienced and could help you to either work through your options or to give you some ideas for patient and family engagement options. As a reminder, you'll receive a questionnaire in the next couple of days, and we do ask that you fill it out. It's required to get the CMEs or the CEUs. And at this time, I'm going to turn it over to Dr. Dugarala to give us some closing remarks.
Yeah, thank you. And thank you, Daphne and Kieran, for your really insightful comments. I think this is we have some really good insights on engaging patients and their families. I wanted to just hit some highlights that I kind of pulled out of this. One of the things I found is that, sometimes you need to talk to your staff and your medical assistants as far as like recruiting patients. They often have really good insights on which patients may have good feedback. And I think Daphne mentioned this about not always getting people who just have positive feedback. It's always really nice for us to hear, but that's not always the feedback that we're looking for. We're looking for improvement. Some of the things that we found with our PFAC is some of the things that practice administrators or physicians may not see, like phones not getting answered or messages not getting to doctors, prescription refills not getting done. Those are the things that you kind of find in those small group settings that patients will give you information on that you may not hear from other feedback. We talked a little bit about social media. What I find is that a lot of it depends on, your patient population. A lot of the older patients prefer Facebook, a lot of the younger patients prefer Instagram. So a lot of it depends on who you want to reach out to. So sometimes you have to do both to try to get, both aspects of that. And of course, professionals with LinkedIn. One pro tip I have is I found when I usually run our PFAC meeting, but I usually can't take notes and talk at the same time or listen, without taking notes. So I usually have one of our MAs taking the notes. I found that very helpful as someone else is taking the notes, and I'm not trying to sit there and try and do two things at once. And I'm more engaged with what patients are saying. The other thing that we found very helpful is actually giving a questionnaire ahead of time to our PFAC patients. They fill it out and it gives us some talking points to start on. We usually have an agenda that we want to talk about, especially like if we want to do new protocols or new changes to our practice. And getting that feedback from patients about before making those changes is really helpful. But having a questionnaire where they give you some of the things they want to talk about, it's a really great starting point. And it gets them, I think, more engaged than just your own agenda. So anyway, this has been really insightful, even for me, who's done, a bunch of these before. Getting tips and tricks from other people is always very helpful. So thank you all so much for taking your lunch on Friday and for attending. And we're hoping to have more collaborations with MDAFP and MHCC in the near future. Thank you so much.
Thank you.
Thanks so much, everyone.
Okay, I put everyone else in the waiting room that hadn't logged off.